All right. I think we're going to go ahead and get started. If everyone from the coffee break area can come on in. All right, we'll take a few minutes as everyone gets their seats. Okay, good morning. Good morning, and welcome to the third annual Global Social Service Workforce Alliance Symposium. Welcome to all of you in this room and to the more than 200 people who signed up to join us through our live webcast. We hope that you'll all take an active part in today's event. I'm Amy Bess, the director of the Global Social Service Workforce Alliance, and we're happy to be hosting this symposium today. We're very thankful for the support from the United States Agency for International Development through the President's Emergency Plan for AIDS Relief, or PEPFAR, and to the GHR Foundation. We're here today to talk about the great strides that have been made over the past 5.5 years to strengthen the social service workforce around the world, particularly since the momentous conference that was held in Cape Town in November 2010. The workforce is absolutely critical to supporting the health and well-being of children and families. They provide an important continuum of care to children and families affected by HIV/AIDS, family separation, violence, disaster, and conflict. They carry out home visits to provide psychosocial support that increases adherence to medications. They work with parents on positive parenting techniques and understanding the effects of violence against children. They're providing important case management services to refugees in Europe and elsewhere to facilitate access to services. By supporting families, they help to prevent the institutionalization of children and the proliferation of orphanages. They're community child protection committee members, frontline workers, managers, government officials, advocates, researchers, and educators. Over the course of the last 3 years since our launch, the Alliance has been proud to support this important work. We've acted as a convener, helped to develop and disseminate knowledge and information on the topic, and helped to advocate for more support and attention to the workforce. The Alliance was initiated due to recommendations from the participants at the Cape Town Conference, and since then has grown to over 900 members from 87 countries. We've helped to build a community of people who are ardent supporters of improving services to children and families. We've promoted learning and information sharing through a webinar series, through technical briefs and working papers, through our online library, and by facilitating discussions at conferences and workshops. We've been supporting the development of new tools through our interest groups. For example, tomorrow we'll be holding an evidence review meeting to discuss major gaps in the evidence base and to prioritize items for a future research agenda. We're also excited to be welcoming 10 new social service workforce ambassadors in September who were selected due to their leadership on issues we'll be discussing today. So if you're not yet a member of the Alliance, we hope that you'll join us and share your experience and knowledge with the broader network. At this year's symposium, we are marking the release of our second annual State of the Social Service Workforce Report. The report features information on ways in which 8 countries in sub-Saharan Africa have advanced the workforce strengthening agenda over the past 5 years in terms of efforts to better plan, develop, and support the workforce. The report also suggests future actions that can be taken to continue and sustain progress so a stronger workforce can better serve vulnerable populations. Many people provided significant amount of help with this report, including Jeanette Schmidt, who is the primary author, and dozens of people in the 8 countries featured in the report submitted information in questionnaires, emails, and reports. More information is provided in the acknowledgement section of the report. Hopefully all of you, as you came in, picked up a copy, and for our online viewers, it's also available on our website. I'd also like to recognize the work of the Alliance Steering Committee members, without whom truly none of this would be possible. I feel honored to work with such an amazing group of people who are so committed and hardworking. So, Steering Committee, could you stand up to be recognized? Great, thanks. We've just finished 2 days of very intensive meetings and strategic thinking. It's been great to spend time with them. As you look at today's agenda, you'll see that the speakers represent an impressive number of leaders in this field. Hopefully you have all looked at the bios of our speakers, as the moderators will be providing only brief introductions as we go through the morning. We also have a lot of expertise amongst all of you in the room and online, and we look forward to everyone's input today. So we're very pleased to have joining us today our first speaker, Gary Newton, who will be providing opening remarks. Gary, as many of you remember, provided riveting and inspiring comments at the beginning of the Cape Town Conference in 2010. He has worked in international development for 35 years, 21 years resident in 6 countries in Africa and Asia. He served as a Foreign Service Officer with USAID for 24 years in a number of positions, including as the U.S. Government Special Advisor for Orphans and Vulnerable Children. So thank you, and let's welcome Gary to the podium.
Thank you, Amy, for that kind introduction, and good morning to one and all. I wanted to begin this morning by quoting one Mr. Louis Bitoka, who gave me permission to quote him. He was my driver this morning, my Uber driver. He grew up in Cameroon and has been in the United States for 25 years. We got talking, and I didn't prompt him in any way, and he said the following, and again, he gave me permission to quote him. In my country, social workers are the smallest group of government workers. They don't put that much emphasis on that because the government doesn't know the importance of childcare. It's never for them been a big priority. It's really sad. It should be one of the top priorities. That's Mr. Batoka. In thinking about what else I wanted to say this morning, I tried to put myself in the 20 shoes of the 10 new Alliance ambassadors Amy just mentioned, who will be advocating the worthy cause of the social service workforce. I tried to imagine advocacy scenarios they will soon find themselves in. A 15-minute agenda item at the parliamentary committee meeting on child welfare in Uganda or Thailand. 30 seconds to deliver the proverbial elevator speech to the Minister of Finance in Haiti or Pakistan. I try to imagine the reasons they'll give as to why funds from tight budgets, be they shilling, baht, gourd, or rupee, should be invested in the social service workforce and not in health, not in hospitals, not in schools, not in roads, not in the military, not in weather forecasting for that matter. I wanted to focus mainly on this challenge, the advocacy challenge, how to make the case in competitive political and budgetary environments for a stronger workforce. But first, let's return to Cape Town, where, as you all know, and Amy just mentioned, 5.5 years ago, at our big conference, we imagined, a la John Lennon, what the world would look like if it were truly child-friendly. It isn't hard to do. It's easy if you try. So let's try again. Imagine a world in which endangered children engender more concern than endangered wildlife. Indices of child well-being are tracked with the same vigilance as indices of stock. Schools are staffed and maintained at the same showcase level as state houses. Politicians fight for the title heavyweight champion for children. Reports of violence against children trigger the same all-out response as a report of a polio case. Cases of child abuse prompt politicians to strengthen child protection systems and not scapegoat beleaguered social workers. Military budgets are dwarfed by giant early childhood education budgets. Schools of social work are as well endowed and prestigious as medical schools. Countries spend 6.5 times more on the young than on the old. In the US, you may know the opposite is true. And finally, a world that has adopted a goal of ending abuse, exploitation, trafficking, and all forms of violence and torture of children. This last attribute of a child-friendly world is not imagined, it's real. As you know, it's an actual target under the UN's 2030 Agenda for Sustainable Development. And I would suggest a target that actually can't be achieved without strengthening the social service workforce. So here's the question: are we getting closer to such a utopian, child-friendly world for children? It can seem, at times, of late, that we're moving in the other direction. We're moving in the wrong direction. We're moving more towards a dystopian, child-unfriendly world when one considers the number of children in acute humanitarian crises, children caught in or fleeing the chaos and conflict of acute humanitarian emergencies, the conflict of fragile and failing states, children adrift, literally, children washed up on beaches, children incinerated in homes, schools, hospitals, refugee camps, children abducted, enslaved, raped, impregnated, conscripted, weaponized. At the World Humanitarian Summit, the UN Secretary General said, "We have reached a level of human suffering without parallel since the founding of the United Nations." And the suffering in humanitarian crises is both acute and prolonged. Conflicts last for an average of 37 years. People displaced by conflict are displaced for an average of 17 years, basically a generation. And it can seem as if we're headed in the wrong direction when one considers children in chronic crises. a lower profile crisis, to be sure, but one that affects many more lives of children. Children living in countries that are stable enough, but who are caught in or fleeing the chaos and conflict of fragile and failing families. Children neglected in poor households, abused on mean streets, starving emotionally in bleak institutions. A 2016 synthesis of data from 96 countries estimated that 1.4 million children experienced violence in 2014. That's half the world's children. A 2015 synthesis of data from 70 countries estimated that 230 million children live in households with the highest risk of dysfunction or failure. In many places, as you all know, acute and chronic crises are concurrent. Chibok is one such place, the town in Nigeria, put on the global map by Boko Haram terrorists when they kidnapped 276 girls from their school in 2014. A Nigerian journalist interviewed families of the girls who'd been kidnapped and published a piece on what she learned from the families. The journalist was surprised, and I'm quoting her article. Excuse me. What had seemed from the outside like one of the greatest horrors to befall a people appeared from the inside as just another great misfortune in a land where tragedy is an everyday occurrence. In other words, these families' lives were marked by pervasive misfortune, extraordinarily high child mortality, no potable water, little schooling, deep poverty, no electricity. Families were struggling to cope with the unspeakable tragedy of the kidnappings in the context of lives scarred by other, dare we say, more routine, quotidian tragedies. The writer entitled her article, "What's Worse Than a Girl Being Kidnapped?" The acute and chronic crises experienced by the people of Chibok and too many other places are no accident, as you know. They're not caused by a bolt of lightning. These crises are man-made, and I say man-made because they are largely man-made. A result of deliberate action, deliberate inaction, willful ignorance, real ignorance, bad policy choices on the part of our political leaders. We citizens, women and men, are of course complicit. Man-made problems like this are fixable by women and men. This is why you established an alliance with 900 members from 80 countries. This is why you're meeting today. This is why you're meeting tomorrow. You, the good people championing the social service workforce, are the fix, or a good part of it anyway. Your workforce helps children and families construct the scaffolding they need for stability and growth. Enough scaffolding at the family and community level, one might argue, contributes to national stability. An investment upstream in a stronger social service workforce could avoid downstream costs of conflict and chaos. A serious investment in this workforce could make UN Blue Helmet peacekeepers obsolete. That's cost effectiveness. Somehow, not everyone sees the social service workforce this way quite yet. The advocacy challenge for this workforce is formidable. Our constituency, vulnerable children, are notable for their small stature, lack of money, lack of power, and lack of political clout. Our constituency is also notable for the gap between the generous lip service we pay them as our hope, promise, and future, and the miserly resources we invest in them. The advocacy challenge is to close the gap between lip service and real service. Gap closing, as you all know, is tough. Many of you have done it. You're all working on it. You compete in political arena not typically overcrowded with people predisposed to helping children. Alliance ambassadors are convening for the first time in September, I understand, to develop advocacy strategies to compete and win in the political arena. Strategies will, of course, be geared to their country context and responsive to the unique array of opportunities and constraints in that context. But that said, I'd like to mention 3 general ideas, and I have a few more. The draft of these remarks was 26 pages long. I'd like to mention 3 general ideas to consider when thinking about your advocacy. They won't be new to you, but please be patient. Idea number 1 is advocacy for the social service workforce should be subjected to the same evidence standard we apply to all other interventions. There's a literature, an evidence base on how to do advocacy with impact. The base is thin. It's recently been thickened. Our colleague, Ginny Roby, has prepared a report for tomorrow's meeting of the Alliance's Evidence Interest Group. It summarizes the evidence, or lack thereof, on questions fundamental to effective workforce advocacy, including what's the association between a stronger workforce and better child outcomes. The report is terrific and timely. Thank you, Ginny, and to all who worked with her. It zeroes in on the evidence gaps, which, when filled, will allow Alliance ambassadors to advocate with even more confidence and from a soapbox of more facts. Idea number 2, be guided by the adage, as children go, so goes the workforce. There's an old saying in U.S. politics, as Maine goes, so goes the nation. In other words, political leanings in the state of Maine were thought to be a bellwether, a predictor of political leanings in other states. You may want to look at the results of the March caucuses in Maine. The variant of the adage used here is meant to suggest that if children are valued, so too is the workforce that helps provide their care, development, and protection. Children should be the middle name of the Alliance. Advocacy for our workforce must be done from a solid base of political support for children. If it's not there, it needs to be built. But you know all this. Idea number 3, make ending violence against children the main reason to strengthen the social service workforce. Judging from today's agenda, this is, or soon will be, the Alliance's priority goal or a priority goal. From an advocacy perspective, this is of preeminent importance. It provides people who you need to influence with a clear and compelling answer to the question, why is it important to strengthen the social service workforce? Data show there is an epidemic of violence against children, and research shows the staggering costs of that epidemic. The gravity of the HIV/AIDS epidemic led to the strengthening of the health workforce and health systems, I think we could say. The gravity of this epidemic, the epidemic of violence, should lead to the strengthening of the social service workforce and child protection and welfare systems. After all, for this epidemic, social service workers are the intervention in large part. No ARVs, no vaccines are needed. The response to this epidemic is human resource heavy. The intervention is simply human beings who can relate, listen, empathize, console, mentor, mediate, coordinate, refer, report, teach, mobilize, confront, advocate, empower, inspire. Simple. The costs of responding to the epidemic of violence with a surge of people with these skills are relatively small. As a longtime fan of the Unitarians, may I close with a quote from a Unitarian minister, a 19th century abolitionist, who coined the now familiar expression, the arc of the moral universe is long, but it bends toward justice. Martin Luther King quoted this expression famously and powerfully in speeches, as does President Obama. But thinking about the metaphor as it applies to our universe, we can be hopeful. The social service workforce is slowly, steadily bending the arc of the moral universe toward justice for children. With every serve and return interaction between caregiver and child, with every street child reunited with a family that's stronger than the one they left, with every increment of capacity developed in fragile families, every pound of resilience built in children born disadvantaged, child protection committees formed and functioning, every safety net strengthened, every research finding used to deliver better care and better outcomes, every reformer increasing family care while reducing residential care while increasing and improving the quality of both, every system that monitors the well-being of children, every parliamentarian who sees child survival and child thrival as two pieces of one policy, every young learner who arrives at school nourished physically and emotionally. You all are bending the arc of the moral universe toward justice for children. Thank you for the good work you do.
Thank you, Gary, for your very powerful remarks. Our next speaker is Cornelius Williams. He has over 25 years of experience in managing child protection programs in Western, Eastern, and Southern Africa with UNICEF and Save the Children. As a child rights advocate, he has been involved in advocacy that led to improved protection of children from sexual exploitation and abuse in humanitarian settings, reduced recruitment and use of children by armed forces and groups, and increased access of children to identity documents, birth certificates, social assistance, and other services. Following Cornelius's remarks, we'll be showing a short video from UNICEF that will feature some of this work as it is happening in Cambodia. So let's welcome Cornelius to the podium.
Thank you very much, Emmy. And colleagues, thank you very much. I'm just from the field. What they keep saying I shouldn't say I'm new to New York and headquarters. But it's a privilege to be here today on behalf of UNICEF at the third Global Social Services Workforce Symposium. First and foremost, let me acknowledge the Social Services Workforce Alliance and the important role the Alliance is playing to build up the body of work that is so critical for so many sectors: child protection, health, education, amongst others. It is also exciting to be here, almost a year after the monumental Sustainable Development Summit, at which time the global community signed up to an ambitious set of global goals. Gary has mentioned and positioned it, what it means for the Social Services Alliance. For the child protection sector, this is monumental as for the first time there are goals, global goals, targets, indicators that concern protection issues such as ending violence, exploitation, abuse, as well as harmful practices. For the MDGs, we felt that we had been left out. We had to virtually scramble and cling to the declaration. Now we have our own targets and goals, and we're right bang in the center of the Sustainable Development Goals. And there's a thinking that there's 5, 8, and 16, but there are other goals that cannot be achieved and other targets that cannot be achieved without child protection. And so the investment in child protection, there's a case to be made. We note that this third symposium focusing on strengthening the community of care for vulnerable children and families, as we consider what is required to achieve the child protection goals and targets, what is critical is the importance of the social services workforce, as we have heard Gary mention. Ladies and gentlemen, it's a great honor to be amongst my fellow members of the workforce today. When I started my career, if they had told me I was part of a social service workforce, I would say, what are you talking about, right? That term didn't exist in my country. At that time, the colonial system of social services had been changed to community development. They were following the discourse around social development. So I became a community worker. I spent the early years of my career as a community and youth worker in my country, working with children living and working on the street. And because I come from this small town in Sierra Leone, and I was part of the privileged group who went to school at that time when literacy was low. People thought, actually, what is he doing walking on the street with his kids, right? I mean, you're supposed to be educated and go on to become a lawyer or a doctor, one of these other professions. So what is this guy doing with his education, sitting on the ground on the street, working with his kids? Unfortunately for us in Sierra Leone in 1993, when the war broke out, I was one of the few Sierra Leoneans who knew how to work with young people. And I was asked to work with the child soldiers. There was no script. There was no manuscript. All the body of work that you have built up at that time didn't exist. And I see colleagues here who I worked with those days, okay? Right? There was nothing. And within 48 hours, we were told 300 children who used to fight will be handed over to you. No script, no manuscript, nothing how it has been done. And we had to provide care for these children and the continuum of care you're talking about. That's where I learned, actually, there's a gender dimension to taking care of children. I didn't know that the girls needed sanitary pads, that the girls needed different underwear from the boys, that the girls should be in a separate hostel from the boys, that the girls had special care and special needs and special way of bonding, that it was difficult for them to release the girls than to release the boys. And so, again, what I wanted to say as I moved around Africa, the points I will cover today will be based on the experience gained through that work and the imperative to use the lessons learned over the last 5 years since the launch of the Alliance to position this sector to contribute to the achievement of the global goals and targets. This is a momentous period for child protection. This is a momentous period for the Alliance. If we lose this moment and not position ourselves, we would not have done justice to the children we are committed to serve. Indeed, it's impressive to see how much social service work at all levels has progressed since then, right? As I said, then there was no script. But as we know, a huge amount of work remains to be done to enable all children to access the services that will help them to fulfill their great potential. I have seen what differences the services make in many countries that I've traveled to, recently and in the past. In Egypt, I saw a program which it's more of an urban program for children who were living and working on the street. And this is a program that responded to children who were affected during the disturbance in Egypt. During the crisis in Egypt, children were being separated from their families. If you were out on the street, you faced great risk. This was a program that responded. In Botswana, in Namibia, I saw the continuum of care. They didn't call it continuum of care. They didn't, it was the same, you go to the same household. One day, the health worker comes and checks if you're complying and adhering to your treatment regime, the kids. The other day, the social worker comes and sees if you have your social assistant, right? And if you filled all the form, if you have your birth certificate. The other day, another person comes to look at your mother, and what is the mother doing? The other day, somebody else comes and look at your nutrition, right? The other day, somebody else comes and look if you're going to school. And when the staff started talking about it, they said we needed to pull all this together and to have one person who looks at all of this and brings us all together. They didn't call it a continuum of care, but they've already thought about it. In South Africa, I saw my colleague from Isibindi, and she didn't recognize me, but I told her, maybe I've had a lot of gray now, but I told her, actually, that I learned a lot from her program. And it's that I quoted her program to our executive director. Our executive director said to me, this upstream that you guys talk about and this downstream, the upstream for policy and the downstream for services. And, you know, they were having this debate, and I would listen to them, and I was like, what are they talking about? We don't talk about upstream and downstream. And I said, let me tell you, sir, about a visit I did several years ago. There's this model where they develop a program, train the social service staff. And after they train them, okay, and they cost the program is absorbed by the government. It's a model, it's absorbed by the government. And the government take over the costing, and it becomes sustainable. So, sir, there is no upstream and downstream. They're providing services, they're developing policy, they're challenging the fiscal space, and in the end, the investment is made for children at different municipalities. I don't know how many municipalities you're covering, but you speak to policymakers. That I can tell you, your model. In Egypt, Ivory Coast, Jordan, northern Uganda, Liberia, South Sudan, Somalia, and Pakistan, for children affected by armed conflicts, we have the knowledge now. We know what to do. And there are colleagues sitting here who's done that work. We now know what we call an interim care center. We now know how to do the reunification. We now know how to do the reintegration. We now know how to make it culturally appropriate. I saw them do it in my country. I never knew that we would budget for a goat, the budget line that says goat, the budget line that says chicken, okay, for sacrifice. I mean, Patrick is sitting there, the budget line that would say actually you need eggs in the Acholi region to do the tradition. So the social service workforce is also culturally appropriate. And one of the things I like about the Alliance is that it pulls people from all over the world. In the judiciaries in Ethiopia, and this is my favorite, they have social service workers in the judiciary in Ethiopia. And I went and I spoke to these people, and I have one of my favorite academics, Bowlby, who talks about attachment. And I asked one of them, do you know Bowlby? And they said, oh, yes. And I said, my God, you know Bowlby? Yeah, the attachment. And they started talking about it. These were social workers in Ethiopia, right? They were trained in Ethiopia. They never went to any Western school. They were trained in Ethiopia. In Swaziland, I asked the prosecutor. There was a little girl running around the court, and say, who's this girl? And they say she's here because she has been raped. And I asked the prosecutor, what drives you? What makes you, you know, lawyers, okay? A lawyer is trained. I have colleagues who are lawyers and they're friends, okay? They tell me I'm trained, the timesheet clicks in my head, and the cost and the salaries clicks in my head. So I'm asking this woman, you left all that and you're a prosecutor, and you're driving this thing. Their conviction rates was going up. They were doing a fantastic job. And I said, what drives you? He said, it's the mission. These children have to have justice. So they're motivated in responding to children affected by violence and abuse. And I've spoken to workers who are also dealing with the challenges of reintegrating thousands of unaccompanied children in Europe. And I said to a social worker from Sweden, they don't know your story. We all know when the minister from Sweden cried when they had to close their border. Why did they do it? They couldn't guarantee the same quality of care for all children, irrespective of your origin. Crunch the numbers. 36,000 unaccompanied children came into Sweden in 2015. Crunch the numbers. what time would you spend in doing the case assessment? They couldn't cope. The quality dropped. They felt actually they were putting the children at risk. The issue of justice, this is Sweden, the issue of justice, the Migration Authority have spoken to us. They are committed to all children in providing the best care they can. They couldn't cope. As social workers, we know that case assessment, if it's not done well, that's the beginning of it. You're not going to go anywhere. And they spend 15 minutes. What's that? That's not case assessment, right? But despite these considerable challenges and the strides that we've made, we heard today from Gary as well. It's reflected in the State of Social Services Workforce Report. The challenges persist that we need to address for the sector to develop on the Sustainable Development Goals and its target. Let me raise 3 issues before I finish that we need to address. The first issue is the need to ensure national coverage of a diverse social service workforce that can address the scale and scope of the problem faced by children in most countries. We need to move beyond small-scale interventions to national action as part of a child protection system that expand the continuum of care. We need to do the investment, and governments need to do that investment. The second issue is that as a sector, we need to strengthen a capacity to apply the principle of result-based management. We need to make a result visible and accessible to policymakers and the public. This would entail developing robust theories of change and result framework that can guide our work, indicators and mechanisms that measures and make the result of our work visible. The final issue is to make the investment in a social service workforce compelling for resource managers, private and public, as a value proposition that will make a difference for children and help member states achieve this sustainable development goal. In UNICEF, we're taking these challenges seriously. In support of as Gary had said, the focus on violence, we are establishing a goal by partnership and a fund to end violence against children, which will be launched in July. The partnership will provide a platform to accelerate efforts to make girls and boys safe from different forms of violence. And we're also working on a package of evidence-based strategies, and it comprises the consolidated and published evidence of key actors in the field of prevention of violence, WHO, CDC, the World Bank, USAID, amongst others. And when we looked at this intervention, one of the weakest components was the one on social welfare workforce. And I'm excited that you have the evidence tomorrow. And we're going to fight to get that evidence in. Noting the importance of evidence and what work will result in accountability for children and families, particularly the most vulnerable, I'm indeed pleased to note that the Evidence Review Forum taking place tomorrow. It's vital for us to know what evidence exists and where are the gaps so that we can help to address the evidence, to inform our programming. In particular, over the next 2 years, I've said to Amy, UNICEF will continue to work with the Alliance to develop the body of work on the social service workforce for results across all sectors. In addition, we will continue to work with the Global Social Service Workforce Alliance to elaborate the wide range of social service workforce approaches I talked about earlier, focus in particular on middle and low income countries. Sectors are now, all the sectors, the WASH sector, the health sectors are now building blocks and strategies of how they'll contribute to the global goals and targets. And we believe that the Alliance should be doing the same and can play a significant role in doing that. In conclusion, on behalf of UNICEF, we wish to extend congratulations to the Alliance and its many champions for your 5-year journey since Cape Town, and we look forward to strengthening a collaboration as we move forward. Before I leave, again, let me visit Isibindi. And they showed us these teenagers came to give testimony. And you know, if you have done social work, sometimes when they take out the children to talk to you, you become a bit jaded and you become this manufactured story. It was not. There was a girl, okay, and my daughter is 17. By 17, she had had a baby, right? My daughter talks about, of course, that's an old man. She feels that not of this world, and she talks about artists and going to college, and she has her friends, and she knows all the media stuff, social media. And this girl thanked Isibindi, and she's thanking these workers because her son, who died, I think at 2 years or 1 year, could stand up and see the sun before he died. That's what she said. The son couldn't stand. He was born with cerebral palsy. The son couldn't stand. And she says, and she cried, and she says, I thank you that my son could stand and see the sun. So today when we go out, if the sun rises in Washington, let's remember all the children and workers and parents that we're working with, that they recall and remember you, that you could help them so that their greatest wish in getting their children to stand and see the sun, which we take for granted, is important. Thank you very much.
វាយជាប្រចាំដូចថាពេលនោះអារម្មណ៍របស់ខ្ញុំមានអារម្មណ៍ថាពិបាកឃើញកុមារស្គមស្គាំងហើយត្រូវបានម្ដាយវាយនឹងខ្សែក្រវ៉ាត់គ្រាន់តែថាវាយភុះមកទាញមកដូចបែកឈាមជាប់នឹងខ្សែក្រវ៉ាត់ពួកគាត់មានរូបរាងស្គមហាក់បីដូចជាមនុស្សមិនបានទទួលនៅអាហារជារៀងរាល់ថ្ងៃអញ្ចឹងប៉ះពាល់ទៅលើសុខភាពរបស់គាត់ហើយការសិក្សារបស់គាត់ក៏អត់បានទៅរៀនដោយកូនអ្នកដទៃមានថ្ងៃមួយពួកយើងសម្រេចចិត្តថាយើងនឹងទៅពិភាក្សាជាមួយនឹងម្ដាយរបស់គាត់ពីរឿងការធ្វើអំពើហិង្សាទៅលើកូនរបស់គាត់ក្រោយពីការពិភាក្សារយៈពេលដល់ទៅប្រហែលជា1ខែគ្រួសារម្ដាយរបស់គាត់បានប្រែប្រួលគឺបានបញ្ជូនកុមារឲ្យទៅចូលរៀនហើយគាត់ឈប់ប្រើអំពើហិង្សាទៅដល់កូនរបស់គាត់ទៀតចំពោះសុខុមាលភាពរបស់គាត់គឺបើសិនជាគាត់រងអំពើហិង្សាហើយគឺពួកគាត់ភាគច្រើនគឺប៉ះពាល់ទៅនឹងសុខភាពប៉ះពាល់ទៅនឹងអារម្មណ៍ផ្លូវចិត្តកុមារបែបនោះភាគច្រើនគឺមុខគាត់ក្រៀមគាត់ចូលចិត្តលាក់ខ្លួនបើសិនជាគាត់កាចខុសពីក្មេងដទៃខ្ញុំចង់ធ្វើការជាបុគ្គលិកសម្រាប់ជួយពួកគាត់ជារៀងរហូតដើម្បីឲ្យពួកគាត់យល់ហើយនឹងបញ្ឈប់អំពើហិង្សាហើយនឹងតាក់ទងទៅនឹងជីវភាពផងដែរ
Wow. I think everyone has really been touched by that video, and we know why we are here today. I'm very happy to moderate the first panel of this symposium. It's a very illustrious panel. There are people who have imagined the world of Gary Newton. There are also people who make the work of all Cornelius Williams around the world known and studied and then recorded, documented so that other people can learn from them. In fact, I would say that this panel represents the best of research, practice, and policy. So the three Ps. So may I call on the stage Lorraine, Professor Lorraine Scher, the consultant clinical psychologist and professor of clinical and health psychology at University College London Medical School. And we have also with us Amelia Peltz, the Senior Gender Advisor and Acting Team Lead, Office of HIV/AIDS Bureau for Global Health of USAID. Please take your seats. And Sarah Stevenson, the Acting Chief of Office of the Global Partnership to End Violence Against Children. So they will each speak for 15 minutes each at the most. And also after the three speakers of the panel have spoken, then we could have an open forum. We have people in the web who are registered and who are listening to us right now, so they will also ask questions, the same as you, the audience. And I think that by the end of this panel, you would really see how the social service workforce can intervene and prevent to end violence against children. So, Lorraine.
Oh, lovely. Thank you. What a privilege to talk to everyone. I'm reliant on my slides magically appearing. Is that going to happen? Just click. Click forward. Yes. There we go, and it happened. It's my privilege to be here today to talk to you about an evaluation of community-based organizations caring for children, and also to pose some very specific questions. Do they make a difference? And what can they contribute to the workforce? So Gary and Cornelius have outlined and hinted at the facts, and hopefully Ginny's going to work on it, that really there is poor evidence, starting from the King report, which woke us all up a number of years ago, who couldn't identify a single study of quality that was worth doing in a systematic review. In fact, it's the study that got the most hits in publications, having found absolutely nothing. We all dream of having a study where you do nothing and you get published and quoted. But there is a litany of subsequent documents of everybody trying to move the evidence base. And evidence-based programming has really become an accepted norm, which is really great, and great to hear Gary telling us about the importance of it. There's workforce challenges, and I don't really even have to talk about this slide because I'm talking to an audience who are already on my side. So briefly, we all know about the inadequacies when they're there, the under-resourcing, the under-skilling, the lack of training, and lack of investment in such training. I have a particular issue about the overuse of volunteers. Where I come from, it's not that they're volunteers, it's just that the national minimum wage goes down dramatically. I know people who volunteer for the T-shirt, they volunteer for the lunch, they volunteer for that small amount of money to get them to the CBO, and that money they walk, and that's the money they take home. So it's not that they're really volunteering, it's just that the minimum amount that they need is so small we can't even conceive of it. And I think there's an effect of using such low skill. Low control, we don't control the work they do, low job satisfaction for them, low growth and development within a role, and the quality of service must be questionable. Is it better than nothing? Well, I like the idea of Sweden. I like the idea of that you gave, that we have to have the highest of standard for every child. And does it matter? And I'm just going to pop up some wonderful evidence from a paper with Lucy Kluver that I've been involved in, where we know that the world has found sort of one of the quick fixes of cash transfers. Cash transfers is a single, reliable, small amount of money. It's basic common sense, poverty, just a small amount, but this great data that shows, does this pointer work? What do I have to do? Point it the right way. No, it doesn't work. Okay, whatever. It shows you that if you add cash, you reduce adolescent girls and boys' risk, but if you add cash plus care, you jump it down even further. You can see the graphs at the bottom that show that very, very clearly. And care is this component that we're talking about. Care is the bit that comes under the community-based organizations that I'm involved in. They're central to supporting children. They fill in where there's a shortage of health workers. They're easy to access. They go to the marginalized children. They go to their homes. They're on the front line. But, huge buts. What is the evidence base? So I'm going to talk to you very quickly about 5 years of research where we've done on evidence base gathering, and I've done a particular analysis for today's meeting looking at paid and unpaid workers and their effects on children. So just briefly to tell you, we got 11 funding partners. They gave us every project that they funded, and we got 588. We did a random selection. We chose 28 from the random, plus another group in Zambia. This was Malawi and South Africa. I'm not going to talk about the Zambia data because we don't have follow-up data on it. But anyway, we tracked these children. We sent teams out. We measured well-being, education, nutrition, psychological health, cognitive well-being, a tranche of measures on all these children. We had a 99% response rate, and we followed the children up a year or so later. So that's just the background. And this was the overall aims of the study, and this is where we were and where we collected the data. And these are the measures we used, quite a comprehensive set of validated measures, just so that we can stand up in fora such as these, and when somebody asks the question, what do we know, we can tell you what we know. Well, we have very high levels of deprivation. This is an audience who will understand that. Food insecurity, 13% of the children were positive. Many of them lived in a shack, lived with a parent who had HIV, and lots of violence, seeing someone attacked, caring for young children themselves, and orphanhood, either having lost a mother, father, or both. What about how these community-based organizations get set up? What happens to them? So you can see the list of them, either by being inspired by the community, set up in the community. And we looked at leadership and how they were comprised. We found 75% had a mixed leadership and 25% didn't. And of the ones who didn't have a mixed leadership, they were entirely women. Some had rotating, some had multiple funding, which renders them somewhat vulnerable to the vagaries of who funds them. And you'll see on my pie chart who does fund them. And what kind of things do they do? Now, they have quite solid frontline care for children. And the issue that I'm going to pick up is the one about paid staff and no paid staff. Of just roughly 1,000 children, we had 722 children who were in contact with in a CBO that had paid staff, and 267 where there was no paid staff. Any paid staff doesn't mean exclusively paid staff. It just means someone was paid. And you can see there's a lot of volunteering around. Staff qualifications are mixed, but a third hadn't any qualifications beyond school. And they tried to do a bit of training within the CBO, very mixed. What was the capacity? Most were full. Only 4 had capacity to take more children, so they really are being stretched themselves. They did lots of things like children visits. What was the dose of what they did? A lot, it lasted less than an hour, but some had some continuity. And the majority saw them at their premises, although their premises are sometimes a room and sometimes a tree or under a tree. This is the kind of services they provide. Mostly in the red for the children is services that they directly provide, but they also assist children to access other services. They become a conduit, and that's really important. And they also provide services to caregivers, you'll see on that slide. And who do they target? Well, they target quite a range of children. This is a slide just telling you by status, and what you can see is that in red is the positive children, and in grey is the other children. And what's quite interesting to me is that the positive children get a lot of the medical referral and the home help, but they need the play and the early child development in the school. So there's a little bit of a misfiring, and that will come with the sophistication and training of a workforce. So we pose 2 questions. This piece of data is a combined database with Lucy Kluver and her team, and to acknowledge their amazing help, where we took from their young carers study a group of children interviewed at exactly the same time scale, but we had strong measures of 1,400 who had absolutely no access to a community-based organisation, and we compared them with our children who were registered in a community-based organisation. So the first question is, did the CBOs reach the most vulnerable children? Maybe not. Maybe they just worked wherever they were, and there's such need. But indeed, they did meet significantly on every variable. The only one with no difference was not school non-enrollment, but you'll see how low that was, under 1% in both groups. And that's really the kinds of solutions you get when you have state-funded free primary education. Our children were young, between 4 and 13. Well, what happens over time? And I think this, to me, is the most important slide, where we compared the children with CBO contact and those without, and we find significant impacts on the violence measures, abuse and domestic violence, on the mental health measures like suicide, depression, stigma, and some of the social measures like peer problems, conduct, and pro-social behaviour, really kind of resounding evidence that the children who have a CBO, no matter what, no matter how specialised, no matter how big or small, they do better than those who don't. So for today's talk, I'm going to end with a few minutes, if I can take you through the analysis that I've done, especially for today, where I compared paid staff by child outcome in a pre-post data analysis. What happens to them over time? So the blue is any paid staff, and the green is no paid staff. So what happens to educational risk? Well, if there's paid staff, it remains pretty steady. There is risk, but it doesn't go up or down. If they're unpaid staff, their risk over time gets much worse. It deteriorates. What happens to self-esteem of the child, measured by a validated measure? They started pretty equally. They both go up. But if they're in contact with somebody where there's paid staff, a bit more professional staff, significantly higher. What happens to behavioral and emotional difficulties? Well, they started slightly different, as you can see, where those 2 graphs start. But with the no paid staff, it gets worse over time. The difficulties enhance, even though they started with lower problems. And with paid staff, even though they were higher at the beginning, it goes down, it dissipates. What about stigma? A lot of the children are stigmatized. There's HIV in the family, there's disability, there's poverty, there's mental health, all stigmatizing. They start at a similar place. Those with the paid staff, it goes down over time significantly. Those with unpaid staff, it simply gets worse over time. Cognition, hardwired measure. This is child functioning, and this we measured with a test by an objective outsider who did something, the Drawman test, quite a nicely validated overall cognition, and another one which was digit span, which is a memory test. And here we find a very interesting finding. Here we find they both get better on the overall cognition, so it may well be that this unpaid staff are really quite good at stimulating the children, playing with the children, educating them informally. And digit span, well, there was not much difference in the paid staff group, but the ceiling for the digit span is 10, so they were doing pretty good, and it didn't change over time, but ceiling's out. But for the unpaid one, it did increase. So here you have this kind of mixed bag of findings. But what the most important thing from my point of view was what happened with the more serious mental problem. A lot of the children are traumatized, they face a lot of trauma of war, trauma of abuse, trauma of seeing a lot of violence in their lives. Started pretty seriously, and both groups pretty ineffective at dealing with the more heavy end of psychological trauma. They are good for the soft end of self-esteem, maybe a bit of stigma, but when it comes to trauma, the CBOs really are not able to function. So I'd conclude that they're well placed at the front line to meet the needs of children and deprived families. There's high uncertainty around funding and infrastructure staff, with an over-reliance, I believe, on volunteers. I really do believe you should pay a person for their job. CBOs effectively reach the most at risk. They effectively intervene. We've got good evidence from our study. A paid professional workforce has long-term benefits, long-term. It affects child outcomes. And currently there's a gap in meeting the more severe psychological need, clearly evidenced. So I'd just like to add that I'd like to end by telling you we really should be putting our foot down. We should make a long statement. And although Gary spoke to us about Imagine, I preferred the Beatles song, I Want to Hold Your Hand. Thank you.
Good morning. Oh dear. I'll try to get away from that. Thank you very much, and good morning. It truly is an honor. It truly is an honor to be here among such distinguished and dedicated colleagues. It really is. I will be speaking this morning about a new technical resource that supports those who are working with children affected by violence. But first, I wanted to start off by setting the stage with some data, much of which comes from Together for Girls, and much of which I am sure you're quite familiar with. So as we probably in this room all know, both girls and boys experience high levels of sexual violence, with girls reporting in higher numbers than boys. Over half of all children experience physical violence before the age of 18, and these rates of physical violence are absolutely staggering, with over half of all children surveyed reporting that experience. Sexual violence has been associated with a range of other negative health consequences, and the data presented on this slide is an example from Swaziland, with the top 3 negative health conditions being HIV and sexually transmitted infections, pregnancy complications, and alcohol use. This is some data from Paho and Alessandro Guedes who did an analysis that shows some of the intergenerational effects of violence. And it demonstrates that children who suffer from physical or sexual violence have higher risks of perpetrating, usually boys, or suffering, in this case girls, partner violence in adulthood. At the same time, children who witness violence against their mothers or stepmothers also have a high risk of either perpetuating or suffering from partner violence in adulthood. So we know that this is not something that just happens in childhood and does not have a lingering effect, but this continues on throughout the life course. And I think that's something that's also very important to acknowledge when we want to think about what is needed for these children, and it really is this coordinated, holistic response for children and adolescents who have experienced violence. And so this includes medical and forensic care and treatment, safety, and this should say protection, not projection, I apologize for the typo, psychological support, support for accessing legal and justice services, and most importantly for this community, social services and associated social support. So in response to a gap at both the international clinical guidance and PEPFAR's specific guidance for its country teams and implementing partners, PEPFAR's Gender Technical Working Group, the Orphans and Vulnerable Children Working Group, and the Pediatric Treatment Technical Working Group all came together and in partnership along with Together for Girls and convened a one-day expert meeting in April of 2012 to develop technical considerations on post-rape care for children under the age of 18 in primary health centers that also provided HIV care. It was the AIDS Star 1 project that led the development of these guidelines and helped to bring everyone together for this convening. Now, these initial technical considerations focused on the clinical and forensic management and do not address in detail how providers can better understand and facilitate the linkages with these critical social and community services that we know are extremely important, and how to provide that comprehensive care for children and adolescents who've experienced sexual violence and exploitation. So following on, this past February, we were very pleased to launch a companion guide. This companion guide were developed and launched in February and focuses on the roles and responsibilities of non-clinical actors in responding to sexual violence against children and adolescents. And the development of these guidelines also followed on a very similar format with a great deal of technical expertise, many of it sitting in the room this morning, was brought to bear under the auspices of the AIDS Free Project to develop this companion guide, as we call it. So one of the graphics in this companion guide really identifies the roles and responsibilities that different actors play within this coordinated and holistic response to sexual violence against children. So the social sector workforce is present in many of these. I've just circled a few here, and I'm going to be focusing in on the red circle today, the social workers and case managers, just as an example. But as you all know, the Alliance promotes the role of not only of the statutory or the government workers, but also the volunteers and paraprofessionals, those who have some child protection training and a designated duty to support vulnerable children. So the other community resources within these circles are important allied professionals who also associate with other professions such as teachers or lawyers or the police, and who should receive some child protection and social service training and coordinate closely with these other social service providers. So as I mentioned, I'm just, for the purposes of today's presentation, I just wanted to focus in on one of those circles that I highlighted, and that's the social workers and the case managers. So the companion guide, it focuses on the who, so all those different circles you saw earlier, the areas of responsibility, and the skills, supervision, and support that each of these groups needs. So, for example, in the case of social workers, it talks about who this group is, what is their area of responsibility where they would be working, and the kinds of skills that are necessary in order for them to carry out these duties. The companion guide then also details the roles and responsibilities of each of these duty bearers or community resources. So in the case of social workers, there's a very, very long list, but these include items such as the case management, which is so critical. And at the launch of this guide in February, we spent a lot of time talking about the importance of case management. So we've got case management. It includes things such as the assessment of needs of both children and the family, helping to mobilize services, to supporting adherence to PEP and other medications, helping children and family navigate the very complex and convoluted court and legal and justice system, as well as leading the overall case coordination for children and families. So in addition to the companion guide that was developed, a series of job aids for the social service workforce personnel were also developed. And there were 4 key ones that are available. One provides a description of the overall case management flow, so all of the different steps and pieces that are necessary for that. It also provides an illustrative referral pathway, giving social service workforce members an idea as to the various modes of referrals to additional services. It also provides a framework of needs that can be used for that critical assessment piece, as well as a referral checklist. So it's not that you just refer someone off into the ether and hope that they get services, but it really does provide a more systematic checklist to ensure that that referral is followed up and that the service is in fact provided. So finally, I just wanted to conclude by saying these are all links to these resources that can be downloaded from the AIDS-Free website. And I would be remiss if I didn't offer much thanks to the AIDS-Free team, especially Marcy Levy and Lynn Messner, who were instrumental in helping to manage the process and pulling together these the companion guide, plus all of the professionals and the paraprofessionals. Many of you are in the room this morning who lent their expertise to making this guide a really essential resource for providing comprehensive and compassionate care for children and adolescents who have experienced violence. Thank you.
Good morning, everybody. I'm going to take this off as well. Good morning again, everybody. My name is Sarah Stevenson, and I'm very pleased to be here on behalf of the Global Partnership to End Violence Against Children. Clicker. We've heard a couple times this morning about the Sustainable Development Goals and Agenda 2030, and how for us as child protection sector and the social workforce that's here, it's been instrumental in terms of bringing together groups of people who want to see an end to violence against children and believe in partnership as a way to make that happen. So as a partnership, we are a combination of government, of children and young people themselves, academic, civil society organizations, faith-based organizations, foundations, and the private sector, who've come together to say, we believe strongly that we can work together to reach these targets and to end violence against children. We are currently housed within UNICEF and are very thankful to all the support we receive from UNICEF. And we have secondments as well from civil society. So for example, I've been seconded from Child Fund. We have other secondments who are from SOS, Children's Villages, previously World Vision, and starting today, excuse me, we have a colleague from Save the Children. Sorry, getting over a cold. So these global goals. We believe strongly that and this is a quote, there cannot be sustainable development without peace, and no peace without sustainable development. And it's a world which invests in its children and in which all children grow up free from violence and exploitation. So we have a number of different goals that as a partnership, we work towards. And Cornelius mentioned this earlier as well, that there's other goals that are in the Sustainable Development Goals that look at health and education, and we also need to be working towards those to realize the end of violence against children. Within this, the global goals, we have Goal 16, which is a world in which every child grows up free from violence and exploitation. And then we also work closely with a world which invests in its children. And that looks at goals addressing poverty, hunger, health, quality education, gender equality, clean water, and sanitation. As mentioned, within the Millennium Development Goals, there wasn't anything in there on child protection. So it made it really hard for us as a sector to come together and to advocate for child protection within national budgets and services. And so within the now Sustainable Development Goals, we have a number of targets that are there specifically to address violence against children and child protection. And these are the ones that are up on the slides now. And there are also targets in there that look at reducing the impact of violence in families, communities, and all settings, and ensure fair and equal institutional justice for all. So I mentioned we're a new partnership. We officially are launching on July 12th. So this is a preview of our strategy, which will come out then, and it's looking at what is end violence. So within our strategy, we have a vision, which is a world in which every child grows up free from violence and exploitation, and a mission, which is the partnership aims to make society safer for children, protect childhood, and end violence against children everywhere. And if you look at our principles, you'll see child-centered, rights-focused, universal, inclusive, results-oriented, transparent, gender-sensitive, and evidence-based. Our goals are to build political will, to accelerate action, and to strengthen collaboration. And we see the drivers to achieving this as movement building, finance and resources, data and evidence, monitoring and evaluation. This strategy came about as a result of an initial strategy, which we called Strategy Zero, which we launched last September in New York. And after a significant review, including feedback from over 1,900 children and young people and over 24 countries, we received comments on the strategy, which we did take into account and mold into this new strategy, which will be launched on the 12th. And some of the additions to this new strategy, which weren't in the previous strategy, for example, include the reference to gender. That's something that we had omitted in the first one, and we're really pleased that it had been pointed out to us so that we could include it into this revised draft. So to build political will, we see this as a number of pieces to the puzzle, because we cannot succeed as a partnership, we cannot reach the goal of ending violence against children if we don't build that political will. And it's about governments committing action to end violence and exploitation of all children. It's about violence against children and the actions needed to prevent them being part of national, regional, and global discourse. And it's about all countries seeing an increase in finances put towards ending violence and exploitation against children. It's also been raised today that we know the economic impact of not preventing violence against children. So we're calling on governments to do, in fact, spend more. To accelerate action, this is about working together across partners to accelerate action to tackle the violence that children face, with a focus initially on what we're calling Pathfinder countries. And these are countries who wish to lead the movement to end violence against children. And this is about national legislation to protect children. It's about children in Pathfinder countries accessing integrated services. And it's about children affected by violence, including those in conflict settings, accessing central services and programs. So you can see your footprint throughout this document. And then our third goal in terms of strengthening collaboration. This is about between countries, within civil society and other stakeholders, and confronting shared threats and developing solutions. So we're looking at a platform for sustainable transnational action and learning to serve as a global forum for learning and to generate and disseminate knowledge and evidence. And I'm going to focus a little bit today on the accelerated action piece, which is about the country-level engagement. I mentioned the Pathfinder countries. These are the countries that have initially come to the partnership to say that they are interested in being leaders and that they're interested in being Pathfinders. We have yet to officially name them Pathfinders, as they're in different levels of process in terms of developing their plan of action and their deliverables. But these are all the countries that have initially come forward to say that they would like to be engaged. Cornelius mentioned Sweden, and I think it's important to mention that Sweden was the first country to put its hand up and say they wanted to be a Pathfinder. And that's specifically because of the reasons that Cornelius mentioned in terms of the unaccompanied children coming in. And they said, we want to learn from other countries how best to solve this problem. And so they wanted to learn from others. And that's what we're hoping the partnership will be. That space for countries to come together, for all of us to be able to come together and share experiences and improve practice. So these are the countries that initially we will be working with. We intend, or I should say we hope eventually to have 193 countries that are part of this. Eventually we may have to drop the term Pathfinder, but it is something that we're hoping all countries will sign on to over the course of the Sustainable Development Goals. So we have until 2030 of the partnership to realize the world in which all children live free from violence and exploitation. So as I mentioned, these are the countries that have stepped forward to say they want to be Pathfinders. And they will receive support for the whole of government. So what we're asking them to do is to come together and have a whole of government response to the prevention and response to violence against children, and explore the relevance of the new global package of evidence-based solutions, which Cornelius touched on as well, to work to prevent and address violence against children and to form alliances. So within the accelerated action, we have what we call INSPIRE. And these are the evidence-based solutions that were found to work in terms of responding and preventing to violence against children. This was developed under the leadership of WHO and in collaboration with UNICEF, C2C, PAHO, Together for Girls, and others in terms of what do we know will work. And so these are the pieces that we're asking governments as part of the partnership to pick up and to work with. As part of the partnership, our director, Susan Bissell, has said social service workers are the unsung heroes as we protect children from violence. And these results that we're looking to have, we will have when we work together with all of you in terms of strengthening the social service workforce. You can see it, Cornelius mentioned as well, within the INSPIRE package, there are clear areas where we need to strengthen the work that we're doing. So who are we? We are governments who are committed. We are an alliance from all sectors of society. We are people who have signed up to the partnership principles. We are those who have prepared to identify, implement, and invest in clear priorities and ready to act urgently and to innovate while working towards solutions. So why have a global partnership to end violence against children? It's about coming together as part of a movement. It's about accessing knowledge. It's about being supported. It's about receiving funding for pilots and experimental ideas where resources are a constraint in terms of accessing the fund. And it's about sharing experiences with other pathfinders and have success celebrated internationally. How will we do this? We're going to do this through analyzing, through aligning, through agreeing, through producing, and through registering commitments. So in terms of our governance and timeline, we currently are still within an interim advisory group. And that interim advisory group has been instrumental in helping us to get where we are in terms of the strategy and in terms of the Pathfinder countries, as well as in terms of INSPIRE. And now as we go forward, we're looking at the July 12th launch. And that will be held in New York and live streamed, as well as a solution summit in 2017. And so at the July 12th launch of the partnership, we are looking for the start of a global call to action where we all can come together and say we are willing and happy to work together in terms of ending violence against children. And so on behalf of the partnership, thank you very much.
Okay. Thank you to all the really inspiring speakers we've had on stage. And now we open the floor. If you have any questions, now is your time. And we also have questions coming from the web and Twitter. So, yes, please. Can you state your name and your organization, please?
Sure. Jill Gay, What Works Association, whatworksforwomen.org. My question is sort of broader for everyone in terms of, are you also, Amelia was clear that she's looking at adolescents, but to what age are you looking at? We know that adolescents are dying of HIV faster than any other age group. And so are you talking about adolescents up to age 18? Lorraine, you said you go up to age 13. Are you going to disaggregate the data for 10 to 13? And also, will you be looking at the work that SASA has done as a community-based organization and working within the schools?
Any?
Should we take a few questions?
Yeah. Other? Yes, Gary?
Anyone else?
Just go.
May we talk for a moment about political will? Sarah, you said that the partnership's number one, was it a goal?
Yes.
Was to build political will. I've been seeing political will for about 30 years in results frameworks, what we used to call logical frameworks, under the assumption column on the right. It would always say, assuming political will. A few years ago, I got interested in how political will is motivated and generated. You all know better than I. There is a little bit of a literature on this. There are definitions. There are actual measures of political will. There are case studies done by a gentleman from American University, Jeremy Schiffman, on how political will for children was generated in Bangladesh, for example, for neonatal mortality reduction, and in Honduras and other places. A really nice set of case studies. How do we do it? I mean, your partnership, I'm terribly sorry, what are you calling them? Not the bellwether countries,
Pathfinder.
the Pathfinder countries. The Pathfinder countries could, in a sense, be seen as countries where there is already a modicum of political will. They've self-identified to lead the way. So to get to a specific question, is there some thinking that you ought to look at the Swedens of the world and find out how they built political will? The answer with Sweden may be as easy as Swedes are born with child rights in their DNA. But that's the question. Thank you.
Okay, one more, and then we'll have our panel. Yes.
Hi, I'm Evelyn Giroux from Global Partners United, but I serve on the Early Childhood Development Task Force of the Global Partnership on Children with Disabilities, which is housed at UNICEF. The Secretariat is at UNICEF. So I often think that each of us go to meetings of our own colleagues and preach to the choir. So I snuck into your meeting today because in less than 2 weeks, all the countries who've ratified the UN Treaty on the Rights of Children with Disabilities, or the rights of people with disabilities, including children who don't get talked to about enough at those forums. Fortunately, UNICEF has developed a youth council of children with disabilities, children and youth, who now come to those convenings. But there will be a side event on violence against people with disabilities, and there's extensive data that my colleague Stephanie Orduleva has published in one of the law journals, an extensive monograph on data, knowing that children and women with disabilities experience the most violence. I hope that disability will be added to your slide. I think that having worked with children with disabilities much of my early career, those with invisible disabilities experience the most violence. You can see a child who can't walk, one with cerebral palsy. That was a very touching story. I think, though, that you can't see the deaf child, the learning disabled child, the child who, like in my family, we have schizophrenia in our family. So I do think and hope and have developed some models that need funding for cross-sector, community-based care to address this issue that strongly includes children with disabilities, their early identification and intervention. So I encourage you to join the Early Child Development Task Force, and there are others among the Global Partnership on Children with Disabilities. So thanks for the opportunity to comment.
Okay. So can we have our panel answer the first 3 questions? I would like to start.
I could have a quick go. The age question is very useful. We started with 4 to 13-year-olds. At follow-up, they were 5 to 14-year-olds. Now they're 17. I mean, our top kids are now 17. They keep growing. And we start with all the skill on early child development, and now we're grappling with understanding adolescents. I think we just are guided by the UNICEF of cut-off age of 18, because I think once you get into older age groups, the issues are very, very different, and your response is so complicated. So I've seen youth ambassadors at AIDS conferences who are 35. In fact, I'm working at being a youth ambassador myself. But so seriously, we would pick it. In terms of political will, I mean, that's the $64 million question. But I will tell you, I'm fed up with children decorating appeals to create the political will, usually by some tearful, impoverished child. And, you know, I want children to be standing up, and we should ban all those heartstring images that I just do think somehow negatively drive politically the guilt will. And disability, I agree 100,000% with you. And in fact, we measured disability, and we have fascinating data on it. And it's part of it. And it's not just single disability. We look at kids with HIV and disability, or kids without HIV but with disability, and fascinating data. So, great.
Yes. Yeah. I think this is working. I can briefly comment in that, yes, the companion guidelines do focus on children up to the age of 18, recognizing that those are very special needs of that age group, and that once you get older, they usually fall more into an adult category. And the guidelines that were available for treating and responding to adults who would experience sexual violence. And so the purpose of this was really to focus on children. So it goes up to 18. I think in terms of the political will question, it's always such an important one. And what we're hoping to do with this companion guide in particular is to pilot it in 2 countries and really help to demonstrate its effectiveness and the utility of this, and hope that as more countries and country teams adopt it, that it will also help to spur more energy and support for the cadres that are working in the social service workforce, specifically focusing on violence against children. And then relating specifically to the issue of disabilities, that is something that is touched upon within the companion guidelines, looking at things like doing assessments and trying to understand what disabilities may be present. So, and the comment is very well received. Thank you.
And for the partnership, the age is up to the age of 18. In terms of political will, it is, as my colleagues here have said, it is a big question in terms of how do we keep that momentum going. By aligning ourselves with the Sustainable Development Goals, that's our leverage for in terms of all the governments have said that they will achieve these goals. We're going to help you to do that. And some of the wording that we choose to use when speaking with the governments is about the evidence-based solutions package. For the first time as a sector, there's been these groups have come together and have said, these are the evidences that we know will work to end violence against children. And for the Pathfinder countries, we're also working with them in terms of costing the budget for what it's going to be to implement that evidence-based solutions within countries. So it's about solutions. We're here to help governments, help all of us to reach the goals and targets that we said that we would reach. We have people working starting on Tuesday all day on working on this. So we can come back to you with more details once that happens. But yes, it is a piece of work that we're conscious of. And don't have all the answers, so would appreciate any advice. And in terms of the children with disabilities within the partnership, right now we see them as part of the inclusive. But it is important to say, I think that, I can't see you, we are also working and are in conversation with some of the disability groups about having a staff member seconded to the Secretariat who comes from the disability sector to make sure that that is top of mind with everything that we do going forward. In the absence of that, we will continue to hopefully strive to make efforts, but we are hopeful that there will be somebody coming in to focus on children with disabilities because it is so important.
2 more questions? Yes, Cornelius? We have 1, 2.
From the webinar.
Oh, sorry.
Thank you very much. Lauren, my question is for you because you've touched on a topic that has been sometimes hotly contested the issue of volunteerism, and I sometimes think that this issue and the discussion also borders on the issue of social justice, which should go with social service work, as you said. Are we concluding that this issue of volunteerism does not contribute to the maximum outcome we would want for children? That the conclusion is it is better to have a paid workforce than to depend on volunteerism. And the cost to the child in the end, the cost, whatever we want, the objective, whatever we want in terms of developmental outcome, we would not get if we continue to do volunteerism. The issue I'm raising it also is that countries, when I was in East and Southern Africa, countries were moving into middle income countries, and the fiscal space was there to have paid social workers, but there were still agencies pushing the volunteerism. And so if we have landed on that.
Very important.
And I have a question here from online, which was posed by Dr. Pam Hedzai, who is a postdoctoral research fellow in social work at the University of Pretoria. How can we build the capacity of CBO's workforce in the absence of sustainable funding mechanisms? For example, in Zimbabwe, most funding goes to established INGOs through the Child Protection Fund, which supports the government and mostly work with a few implementing partners, leaving out the majority of CBOs. Additionally, the limited funding from donors does not cover salaries and other administrative costs. How then can CBOs attract qualified professionals or retain volunteers?
Okay. Lorraine, I think those two questions.
Well, they're curiously linked, aren't they? And my own views will come through to you, Cornelius. I really do believe that my data speaks quite loudly on volunteers. It's a very hard one because well-intentioned volunteering is a good thing, but at what cost and at what price and instead of what? And we have to take into account some of the negatives. You know, Linda Richter wrote a beautiful paper on orphan tourism, where volunteers come in and play with kids for a little bit and go away. And do we do more harm than good? And I just think that if I was having brain surgery, I'd kind of like to have the qualified brain surgeon. If I was going to have my tooth extracted, I'd prefer not to go to the volunteer. And if I was going to have my kids' social welfare catered for, I would kind of like to know that somebody had read the manual, unlike you in Sierra Leone in the 90s. So my voice, maybe I'm driving my data, my voice is that if you want quality, you pay for it.
Yeah. Being the moderator, I'd like to take advantage. Following up also what the person from the web asked, so if as what Cornelius said initially, that the social service worker is the intervention in a lot of cases. So couldn't be that, funding agencies will fund the intervention, and this intervention is salary of the social workforce worker? Somebody would like to ask?
Just following up on the volunteers and paid workforce. I think one of the things that I found when I was traveling with my boss last year in Cambodia and in Vietnam, they were actually talking about that they actually did have trained social workers, but that there were no jobs that was particularly government funded, that these jobs or the positions were funded through NGOs or IGOs, and that the government really wasn't stepping forward to create the positions. So I didn't know if you could speak to that or how we could build more political will, essentially to have a sustainable workforce for when the NGOs leave or cannot fund these positions.
Right. Yes, Karen, you may have the last question.
Okay, thank you. I'm Karen Blythe from Israel International. And sorry, my question is to Amelia and to maybe any other donor colleagues here. Are we designing projects with government counterparts at the country level that can really lead to the strengthening of linkages between clinical and community services for children and adolescents and reducing gender-based violence?
So our panel, you're free to answer all the questions.
Okay. Well, I can start. So just to understand the question, are we funding programs that
Are they being designed in a way, whether it's U.S. government or Bill and Melinda Gates Foundation, are they being designed in a way and implemented that will really lead to these results?
such
know,
as reductions in violence?
Yes,
Yeah.
and addressing all the issues around social welfare.
Yeah, that's a great question. I mean, I can't speak for the Gates Foundation because I don't work for them, but I can try to speak for USAID and for my small perch, in that I think just a few weeks ago, in fact, we had an event that highlighted some work that PEPFAR funded over the course of about 3.5-4 years, which was a very large gender-based violence scale-up initiative that was done in Mozambique, Tanzania, and the Democratic Republic of the Congo. And it was focused very much on both the provision of clinical post-rape care services, quality services, as well as the prevention aspect, so that more of the community piece, and then looking at referrals and linkages between community and clinic as well. So it was a rather large initiative, and it demonstrated some very, very positive results, not just in terms of the number of people reached, looking at that quantitative results component, but also looking at some of the qualitative data that was coming in from interviews from different host country governments, community-based organizations, doctors, social workers, and really commenting on some of the shifts in norms and in attitudes. A very rigorous evaluation of this initiative was conducted in Tanzania that also showed some very promising results, both in terms of the number of people who were accessing services at the clinic, as well as these attitudes towards the acceptance of violence as well. So I do think that there are some promising programs that have been developed and funded and implemented by a wonderful collection of partners, both international, domestic, and host country government. Can we do more? Absolutely. There's always more that needs to be done. But I think we're moving in the direction whereby we are seeing more and more evidence of the kinds of programs, both for gender-based violence prevention and response, that do in fact work, as well as evidence of things that are not so promising and that don't work as well and that we need to be moving away from. And so I do feel that we are heading in the right direction, always needing to do more. There's always more of a need. It always takes longer to do some of these things. There's always more policy change that needs to be happen. There are always more gatekeepers or stakeholders that need to be reached. But I do feel that I'm hopeful, optimistic that we are moving in the right direction.
Any other additions?
I would comment that the level of your workforce also feeds into the political cycle. So if your workforce are high achieving, highly qualified, they sit at the table where decisions are made. When your workforce is predominantly volunteers, they're not at the table where those decisions about funding are made. Give an example, in India, 1% of GDP is spent on health. So yeah, your point about there are people who are qualified who can't get the jobs, that's where the problem lies. So it's not we just don't have people. It really is a cycle, isn't it? We have to train the workforce. We also have to train the employers. I don't think there's quick solutions, but we're sitting here. That's a big step forward.
And just to say that from the partnership side, we will be having this solution summit in 2017, and that's where we're hoping to bring together some of this evidence-based solutions that you're talking about, both at country and national level, but also regional and international level, in terms of what are those evidence-based information that we have in terms of making advances.
Okay. Thank you. I'm sorry we have to cut short our panel. As you could see, they are such experts. You can still get to meet them when they're seated down. But we have to go to the next panel. Thank you, everyone. Thank you. Thank you.
And we'll reconvene at 11 o'clock.
Hi, can folks start taking their seats for the next session, please? Do you guys have mics? Can I just ask folks to take their seats for our next two great speakers? That's fine. Oh, sorry. Do you not have any? I had coffee and water. Yes. Sorry. My life. Thanks, everybody, for coming back. My name is Gretchen Bachman, and I am at the Office of HIV/AIDS at USAID, and I work on the PEPFAR program, particularly with orphans and vulnerable children. I'm really pleased to see everybody here today, and really so very excited about the work that the Alliance is doing. And Amy Bess, I don't know if Amy was introduced before, but Amy is definitely the driving force behind the Alliance as the coordinator. So if you just want to give a wave, I think most people know you. Some really, really fabulous presentations this morning. And I think one of the things that is so important, and I think we're going to hear from our next two speakers, is really about the continuum of care for children and for families. It's going to be very hard to end violence against children if we don't also end violence within the household situation, and violence particularly against women and girls. And so I think that they're, yes? I think that some of the discussions, I think importantly, are going to look at that. So our first speaker is Patrick Onyengo Mangan, who is country director of TPO in Uganda. And Patrick has been a development practitioner for over 18 years, which isn't so long, actually. from where I sit. But long enough, and lots of hard work in there, working with children and families living in difficult circumstances. Patrick has really done a lot working on building programs for parasocial workers in care and protection of vulnerable children. And as a result of this work, he's a steering committee member for the Alliance. He's also an advisory board member for the Columbia University's Child Protection and Crisis Learning Network, a member of the Community-Based Child Protection Mechanisms Global Reference Group, coordinated by Save the Children UK, a member of the AfriChild at Macquarie University Advisory Board, and a member of the Emerald King's College London Project Scientific Advisory Committee. And somehow with all that, he has lots of time somewhere in there to do a really great program in Uganda. And that's what he's going to talk about with us today about TPO. So welcome, Patrick.
Thank you, Gretchen. It's a pleasure to be here once again. I've had the privilege of making presentations at the last two symposiums, and it's always interesting to hear and be part of these discussions. The work I'm presenting is partly done by TPO Uganda, but it's largely done collaboratively with other organizations in Uganda. And I'll be sharing with you some of the pathways that we are working on to move children out of vulnerability and how we're trying to roll them out across the country. I'll begin my presentation by taking you through just a brief outlook of the social service workforce in Uganda. Most social work practitioners, about 70%, are employed in the NGO sector. 15% are employed in the government, local government service sector, and then 10% in CBOs and the other in commercial agencies. The absence of a legal framework for social workers has blurred the terrain and boundary of the social work profession. And social work practitioners are called different names, from social workers, community development workers, to child care and youth workers. There's also a lack of clarity in these qualifications and requirements for social service workers. And in the absence of a social work council, it becomes quite difficult to regulate the sector. And yet a well-trained social service workforce is essential for the creation of an effective system of social services that can enhance care and protection for OVC. And therefore, what have we done in absence of this professional social work cadre? And working for a small, medium-sized NGO, which TPO Uganda is, has given us the opportunity to try out innovative ways of engaging directly with community workers. And that's how we ended up working with the community psychosocial and parasocial workers. And so these informal support groups can play a very significant role in the care, support, and protection of children. Sorry, I forgot that altogether. So the context of HIV/AIDS care in Uganda, I would like to share with you some statistics there. 11.3% of children in Uganda are orphans. 38% of Uganda's 17.1 million children are vulnerable. And children below the age of 15 years account for 11% of all HIV/AIDS cases in Uganda. And then 2/3 of new infections are occurring among adolescent girls. And it's important to look at these statistics because they then talk a lot about what the role of the parasocial workers is in as far as moving care closest to the household. Reliance on family and community networks to provide emotional support and home care. Traditionally, where you don't have, we saw in the morning, the lack of adequate care facilities, few social service workers, therefore allows us to requires that we rely a lot on family and community networks. Economic hardships and poverty have further weakened informal systems of care. Complex social problems and the magnitude of HIV/AIDS burden on family networks places more demand on a more skilled yet absent professional workforce. And then we have a lot of district units that are coming up, political units and therefore pushing local government systems below optimal personnel levels. How about in the context of children living outside family care? And monitoring reports on child care institutions indicate that up to 55% of children's homes operate illegally. At any one time, there are over 10,000 children on the streets and 40,000 living in over the 500 child care institutions. 18% of households in Uganda have at least one orphan, and 1 out of every 3 households have a foster child. Sorry, I'm forgetting to move this. Of the 500 registered child care institutions, 85% have no proactive resettlement programs. 75% have no social work capacity and rely on all sorts of auxiliary workers, and 80% have no child protection policy. Now, so what do you do in this context, where there are multiple problems as far as caring for children and families affected by HIV/AIDS, and yet at the same time, there are resource constraints as far as the availability of social workers? And the pathways I'm going to share with you are rooted in practice, and we're trying to test them to build evidence around this practice. And the pathways are based on a holistic program approach and a skilled, well-trained, and supervised workforce that comprises, at the institutional level, of probation officers, NGO social workers who do support supervision, parasocial workers, and informal structures, on the other hand, who facilitate access to essential services such as home visits, family mediation during conflict, family tracing and resettlement, and who provide temporary abode to unaccompanied children. And all these 2 levels coming together to deliver services in an integrated manner. The pathway 1, like I mentioned, is developed collaboratively and a project we're implementing together with Child Fund and RETRAC. And the project is looking at removing children from care institutions and resettling them into their homes. I hope you can see that and make sense out of that diagram. So that's the pathway number 1. So the first box over there has local government. And for each step, there are very specific roles identified for the caregivers. The local government is involved in capacity building, development of tools, quality assurance, periodic monitoring, evaluation, and managing records and documentation. And then at 2, you have the remand homes or the child care institutions. They are largely involved in development of improving case management protocols and supporting children to move to their homes. We also have community support structures here at point 3. And this forum, together with the probation and social welfare officers, constitute what we call the team around the child. And it's important from what we have seen that the team around the child is made up of community people who live within the communities where the children interact and find support. And then you see the team around the child from here then moves down to connect with the parasocial worker, who is very closest to the households and the family. And the parasocial worker does home visits and then moves upwards and goes the other way. And then you have the alternative care panel, which is a community-based panel, which vets some of the families that are taking on care for these children and ensures that minimal harm is committed. And therefore, we found parasocial workers to be an integral layer. In Uganda, over 11,000 have been trained under PEPFAR funding as parasocial workers. There have been efforts to develop uniform training curricula. These parasocial workers provide home-based care, mobilizing families for HIV/AIDS clinics, identifying and registering vulnerable children and families affected by HIV, and guiding households on where to access services. They also work with health workers to mobilize households to take their children for health community outreach clinics, as well as immunization programs. And we found parasocial workers to be a very good conduit to sustaining child protection and HIV/AIDS care and treatment knowledge within the community. How can we strengthen this model? In the first panel, we talked a bit about voluntarism and the challenges of relying on volunteers. And we are trying to integrate some models, including economic empowerment models for the parasocial workers, where they come together as a group and are supported to engage in economic activities that sustain their economic well-being. There is need to enhance selection criteria, taking into consideration age, gender norms, and good conduct. Parasocial workers live within the same communities and culture and social norms where abuse takes place. And while the roles of governments and NGOs are clear, there is a need to continue to define parasocial worker roles, linking their work to legal frameworks. And then NGOs working at this level should involve local governments to ensure harmony in approaches, and then documenting stories of change and sharing these stories of change with others can be quite inspiring. I keep missing these slides. So, Pathway 2 is an integrated program approach which is adapted from a recently concluded 5-year program implemented by AVC Care, TPO, and FHI. And this looks at, within an integrated program, what are the different interventions available and who is available to deliver these interventions. The circles here in blue, the small spheres, are the interventions. The farmer field schools, village saving schemes can be implemented and delivered through private sector linkages for market access. Supervision could be provided by district probation and production department, and then NGOs can provide the agriculture inputs and economic models. Family mediation interventions, parenting skills. The parasocial workers are trained to hold regular parenting sessions and to intervene in domestic violence. So they live within the communities and they are therefore very much aware of what is going on, the forms and types and prevalence of abuse. Schooling for children for social norm change. The parasocial workers monitor and report incidents of child abuse. They also help address harmful practices, and then they mobilize for counseling and testing clinics. And then the other is the youth apprenticeship, which has the youth government schemes also having a very direct role to play. And lastly, in another program, we have worked with parasocial workers in HIV/AIDS care and treatment using an innovative community-based 4-tent model. You can see the gentleman doing the testing here. There's a police officer there. And there are volunteers involved, the parasocial workers involved in delivering these services. It's a one-stop center. In each tent, you have participants benefiting from different services, including counseling, testing, nutrition, and legal support. The high-risk populations receive behavior change communication messages, and then there are numbers there as far as they reach over a 6-month period. And what we are seeing is the parasocial workers are very integral to this type of work, especially in resource-constrained communities such as where we operate in Uganda. The circumstances you find in Uganda are not different from what you find elsewhere. But it's important to recognize that they cannot do much. They need a high-level skilled workforce that supervises, ensures quality control, and provides backstopping. Thank you very much for your attention, and we can take any other questions.
Patrick, I think maybe we'll take questions at the end.
Yeah, okay.
Sorry. Let me go back around here. So our next speaker, who probably doesn't need much introduction, is Zeni Dumbadu. She is Deputy Director of the National Association of Child Care Workers in South Africa. She's worked for a long time with children in South Africa in direct service provision, and she's also been a major contributor to children's policy and legislation. She's worked as a consultant to the Department of Social Development, as a trainer in child and youth care work, and since 1997, she's worked as the Deputy Director of NACCW, National Association of Child Care Workers, where she's contributed to the professionalization of child and youth care work, which she's going to talk to us about today. And she is the vice chair for the Alliance. Great. Thanks, Zeni.
you. I appreciate the opportunity to be here speaking today about case management teamwork, bridging social work, child and youth care work, and auxiliary work to promote the well-being of children and families. I would just like at this stage to acknowledge that my presentation has been contributed to by a whole lot of people in South Africa who I'm sure are online, and I just want to say thank you to them for their contribution. I'd also just like to make a special acknowledgement to Anita Sampson from USAID, who is here today. She is our representative in South Africa and has been critical in the success of the rollout of Izibindi project in partnership with South African government. So thank you for all that you mean to us and have done for our work. Just a quick overview of my presentation. I'm going to talk about case management and multidisciplinary case management within the Izibindi project. We'll talk a little bit about the approach and principles that inform multidisciplinary case management, some of the key elements, and then I want to just clarify the difference between case consultations and case conferences with a couple of case studies as well to round up. Ricks and Charles would say that for effective practice planning, it is critical that practitioners understand that the complex nature of planning involves many choices and therefore many discretionary judgments. Best not to be made on your own, best to be made in multidisciplinary teams with a range of other perspectives and opinions that would actually guide your decisions so they are always in the best interest of families and children. I put this picture out to start because I think that here's an example of social service workers working together with families. There's a social worker, a child and youth care worker, a caregiver who happens to be a granny, a go-go in this case, and the children are participating in an important case conference within the Izibindi model. The Izibindi model, just to describe it quickly, delivers services to children and families in South African community through trained child and youth care workers. This is now being done in partnership with South African government and of course with the support of USAID PEPFAR. The services are aligned to South Africa's Children Act, and we provide services as prevention, early intervention, and child protection levels. Now, our case management approach is informed by a developmental, strengths-based framework. So family plans and individual plans are put in place in order to guide child and youth care workers in their service delivery. Just to say a little bit about South African government's mandate to scale up Izibindi, the Minister of Social Development said that within the period of 5 years, from 2012 and 2017, there should be 10,000 child and youth care workers trained and developed in South Africa within 400 Izibindi projects. Our progress to date, we are at the point of approximately 7,000 child and youth care workers who have been trained or who are in training, and 340 Izibindi projects are functional. I think those mentioned before about CBOs and FBOs and developing them and their significance. And this shows that we're not just building a workforce, we're strengthening non-government organizations in the deepest rural areas in South Africa. But I think most importantly, we have serviced 270,000 children since inception. And in addition, I think an exciting part is that 7,000 childcare workers at this point are legislated. They are regulated, they are registered with the South African Council for Social Service Professions. So they are a significant workforce in South Africa, a recognized workforce. So what do child and youth care workers do in the case management program? They provide child and youth care services through undertaking therapeutic life space work with the child. Child care workers work with children. They supervise foster placements and they're mentoring child-headed households. So what's case management? It's a way of organizing, carrying out work to address the holistic needs of the individual child and his or her family in an appropriate, systematic, and timely fashion through both direct support as well as referrals, and of course, in accordance to the program's guideline, in this case, Izibindi. Now, multidisciplinary case management brings together more than 2 groups of staff from different professional backgrounds to address the holistic needs of the child and family. They come in with different areas of expertise in order to organize and carry out this work in this holistic fashion. So it is a collaborative process of assessment, planning, facilitation, and advocacy. In South Africa, the multidisciplinary team may include social workers, child and youth care workers, social auxiliary workers, community development workers, and the allied professions, health workers, psychologists, educators, teachers, and police. In the Izibindi model, it's generally the child and youth care workers, the social workers, the teacher, and the police who are the key multidisciplinary role players. So the Izibindi approach to multidisciplinary case management is really focused on teamwork. We need to understand each other's roles in a multidisciplinary team. We need to respect each other's expertise. We need to identify who is going to be leading in a case, and particularly in statutory cases, child protection, foster care, it is a social worker who is the lead facilitator in the case management process. Ricks again and Charlesworth say that practitioners from different theoretical back orientations use similar processes and strategies to achieve similar goals in their work. So there has to be a shared developmental framework from which you function. You can't be too disparate in the way you come from. And in South Africa, we use the Circle of Courage as our joint assessment tool, social workers and child and youth care workers and all social service professions. And we are guided by the principles of the developmental approach. So we talk about strengths-based work, strengths-based interventions, strength-based assessments. We use crisis as an opportunity for change. We respect diversity, cultural diversity, but also the diversity of different workforce. And of course, the issue of participation. We believe in the participation of service recipients. We believe they bring in expert knowledge because they understand their reality the best, and families and children are key role players in the multidisciplinary team process. So, multidisciplinary case management within Izibindi is informed by the standardized process of assessment, planning, implementation, and review. Decision-making is guided by active listening, tolerance, problem solving, and I like the last one, creative negotiation, where all role players believe that they are actually participating in the decisions that are finally agreed upon. And of course, children must be part of case conferencing as much as possible, and according, of course, to their capacity, their age. Children must know why there is an assessment or a review taking place for them. Children must understand that their best interests have to be expressed and explored within a case conferencing process, and the child's ability to make choices and decisions has to be encouraged, nurtured, and respected. And the childcare worker in the multidisciplinary team plays a key role in preparing the child for the case conference when it takes place. Another picture of a child participating, a case conference being held in a family home, with again the child and the family involved. Some of the key elements in multidisciplinary case management is that you've got to identify which cases require the case management. And generally in South Africa, within Izibindi, we're talking about foster care cases, child-headed households, child abuse cases, high-risk cases where children are suicidal or there are serious behavioral issues that require attention. So we organize and carry out our work individually and jointly. So the social worker and the childcare worker and the health worker or the teacher would be doing what they're supposed to do. And sometimes we come together to consult and do what we need to do together. For children who are in foster care, as I mentioned before, or child-headed household, there's all statutory cases in South Africa, and the social worker remains key responsible, working in partnership with the other team players. And then we together engage in team consultation and case consultation and case conferencing. Just another quick picture, an example of a family case conference in a church hall. There's possibly a reason why we couldn't meet in a family home in this particular case. So what are case consultations? Case consultations provide a way for the multidisciplinary team to engage on an ongoing basis on critical cases and complex problems. There's a lot of information sharing. So the social work and childcare workers share information with each other. They give referral updates, they make observations, they share those observations with each other, they follow up on progress and report to each other, and they identify if there are emergencies and risks Okay, so how frequently you meet is as long as you do need to meet. The participants, I've made the point before that it's the social worker, childcare worker, and of course records are kept to hold people accountable. Responsibilities and roles are clarified. Case conferences, on the other hand, provide a forum for formal assessments, planning, and reviews. It's a much more formal, organized process where we actually review the development of the development of formative or initial assessments. So assessments are going on all the time. Now we're actually looking at reviewing them, agreeing upon the developmental plan, making joint decisions, giving feedback on what are the progresses and the challenges. And of course, in a case conference, you can observe the interaction of the different role players, the family, and how they engage with each other. The venue is generally the family home, and sometimes we would use the community hall, the social worker's office, or even the family garden. And there is a clarity of roles, like I said before, and a proper recording of a formal case conference. The next picture shows you, in this case, a social worker, child and youth care worker, and family having a meeting outside in their yard. It's likely that their home is too small to accommodate everybody. So the multidisciplinary case management process is one of assessment, planning, implementation, review. Assessment, planning, implementation, review, and sometimes the planning will be that formal case conference. Each practice situation has its own time, place, location, and circumstances that make it unique, and this process allows for that to be respected. 2 quick case studies. This is an orphaned child whose parents have died and the maternal and paternal family are in conflict. The child is actually staying with the paternal family, unhappy. School teacher reports not doing well in school, grieving, struggling, wants to go to maternal family. There is a foster care grant in the process of being finalized, so of course the paternal family also wants to be part of receiving that grant. The child and youth care workers offers therapeutic life space work. They visit the child at home, they visit the child in the safe park, they visit the child at school. They have discussions with the social worker. The social worker says, well, let's set up a formal case conference, bring all the role players together. This is one where you wouldn't have it in any family home, but in a neutral venue. They identify who's going to be part of the case conference, set up the venue, prepare the child to participate and hold the conference. The case study on the other side with the process undertaking shows that there's an initial assessment, a case consultation process that's happening, planning takes place, again planning and assessment till the formal case conference actually takes place. At this conference, the decision is more likely that the child should be moved to the maternal family. So the social worker goes off, verifies information so she can finalize the foster care placement with the maternal family. And then the child care worker takes on the responsibility of continuing to provide supervision of this foster situation and feeding in through the case consultation process with the social worker so that she's satisfied that yes, that the child is growing well. Just to say, HIV/AIDS counseling and testing is critical in Isibindi. Recently, just before World AIDS Day, we did a massive campaign to actually work on the testing of children. We had 220,000 children from 68 Isibindi projects that were tested in this period of time of about 4-5 months. And I just wanted to say that while that is a number that we're quite pleased about, because it actually showed us some very interesting information about those who were found positive. But I think more importantly, my next slide wants to say that every one of them is a family and a child to us. They're not a statistic. They're real people who have real stories to share. And in one of the cases, we're talking about a young mother, 23 years old, HIV positive, living in a remote community. She's got a baby of 18 months old who's HIV positive, no follow-up with the health sector. The child and youth care worker pick it up and follow up. They do a home visit. They realize there's no food in the home. They work with the implementing partner, the CBO, accesses food parcels, peanut butter, I believe, as well. Got them eating immediately, reports to the social worker. The mother is seriously distressed about the situation, arranges for a psychologist to see her, arranges funding for her to go to see the psychologist on a weekly basis to start off with. Gets the support from the social worker to get a letter to go to SASA, which is our social security, gets a grant, a child support grant in place, works with the nurse. Now, this was a lovely part of the story where the community leaders and the childcare workers together approached the clinic and said that you have a mobile clinic that bypasses this community. Please come to our community so that you can actually visit on a monthly basis, which is obviously of benefit to all people in the community, and that actually did take place. So all of this is your formative assessment or your initial assessment leading to the formal case conference that is going to take place, where decisions about the family and their future is going to be taken place by a multidisciplinary team, including the health worker and others in this particular case. Another picture of a case conferencing in a rural area. I wanted to put these pictures in because I wanted you to understand that while case management and multidisciplinary case management is quite a sophisticated task, it actually requires a lot of skill and a lot of capacity of the role players to make it happen in a way that's appropriate. But it can happen in simple contexts. It can happen in family homes, and in fact, that is the value of the work that we've done. I know that Cornelius mentioned the Izibindi project earlier, and you asked, well, in how many districts are we? We have 38 districts in South Africa. We are in 36 districts at the moment, servicing with the Izibindi project in the rollout plan. And I know that the others here sang some of the Beatles' old songs as just reminding us. And I wonder if I could round up with my favorite song. It's not a Beatles number, even though I do love the Beatles, but it is the greatest love of all. It says that I believe that children are our future. Teach them well and let them lead the way. Show them all the beauty they possess inside. Give them the sense of pride to make it easier. Let the children's laughter remind us who we used to be. Everybody is searching for a hero. People need someone to look up to. I never found anyone to fulfill my needs. It's a lonely place to be, so I learned to depend on me. I think that what we want to do in Izibindi and what we try to do is see if we can stimulate the laughter again in our children and let them find the heroes inside of themselves. Thank you very much.
Thank you so much. You can hear me, right? Thank you so much. Really great presentations, and thank you for underlining the role that the parasocial worker and social worker play together to bring the family and the children and the community in to resolve issues so that the family and the children's situation improves. I think that's really so key to what a social worker does. So thank you for that. So I wanted to see if we have questions from our audience for either of our speakers. And we have quite a few. Gosh, I don't know where to start. Let's start with Florence.
Yes, thank you. Thank you for this really great presentation. I have a question. You've got two different types of parasocial workers. And we know, I'm not entirely clear, they're volunteers. Are they getting any type of pay or subsidies? And one thing that we do know, even if they are not getting paid, is the cost of the work, the cost of home visiting, the cost of meeting some of the immediate needs and so on, is actually very considerable. And that's what I've always found with social workers I've worked with. That was the biggest challenge. How do we get a motorbike for them? How do we, it's an enormous amount of resource. So how did you, in these cases, both Uganda and South Africa, how are you managing that cost? That'd be great to hear.
Thanks, Florence. So we'll take a few questions. I think there was another one, over here.
Yes, my question is for the first speaker from Uganda. And my question is, I have a two-part question. And first part is, to what degree does child soldiers factor into the work that you do? And I'm asking about that because I am collaborating with a group called Seraro in Uganda that focuses on child soldiers. And they came to my university, and the response from my university with the students and the faculty was to send supplies. But then the question was, how can we engage in a more sustained effort whereby we can serve as a resource to some of the service providers? And I was wondering if any of the pathways that you're looking at involves the utilization of technology, so those of us who cannot be physically present may be able to contribute in some way.
Great, great. Let's just take one more question over here in the back.
Thank you. My name is Tiara. I work for Migration and Refugee Services at USCCB, which is the Catholic Church's refugee resettlement agency here in the United States. And I was wondering if you could speak at all to the impact of migration and refugees in your areas. I know that both Uganda and South Africa are hosting many migrants and refugees, and any special considerations or challenges that arise from serving unaccompanied migrating youth in your area. Thank you.
Thanks. So Zenny, do you want to start us off on the workforce question?
Okay, just to say that child and youth care workers are a distinct profession that's recognized in South Africa. And the initiative of South African government to scale up was an initiative to create jobs for child care workers. So child and youth care workers within the Izibindi model are at the moment, while they are in training, receiving a stipend. But already 2 provinces in South Africa have started paying them salaries. The fact that we have the statutory regulation, the professionalization of childcare workers, the fact that they function by a code of ethics has also brought status to child and youth care workers as an equal profession with social workers, working alongside social workers with unique skills that they have to offer. I think that we are not at the point where I can honestly say that all childcare workers are being paid salaries and are being paid what they deserve. But I think we're walking that journey hand in hand with South African government.
Thanks, Zenny. Patrick?
Yeah, I just wanted to add to the parasocial workers model in Uganda. It's not a paid cadre, so the demands on their time is very minimal. For example, I know some who are required to spend about maybe a couple of hours a week, and then they are attached to an NGO working within the area, but they are supervised by the district community development officer. So you minimize the time required of their activities to take care of their business. But also in instances where they have been used, for example, the village health teams or the parasocial workers, there have been instances where they have been used to collect data, they would be paid. So yes, sometimes when they are used for specific activities, they are paid for those activities. And like I mentioned, we're trying to innovate and see if we can do group economic models targeting the caregivers specifically as well. Yeah.
So did you want to address the question about the child soldiers, or either of you?
Yeah.
Just in response to the issue about migrants, in South Africa, the Izibindi model embraces unaccompanied minors, migrant refugees working within the Izibindi project. They play in our safe parks with our children. They are protected by our Children's Act and receive the full services offered. What is interesting is just recently the NACCW was approached by the UNHCR to look at whether we could support the development of child and youth care workers in Zambia, in the Solwezi camp. And we have just successfully completed training and assisting them set up a safe park in a camp. So the Izibindi model is obviously adaptable to a different context.
On the child soldiers, no, these programs are not within the context where we're working with child soldiers, but similar approaches were used much earlier in the early 2000s, working through child protection committees, which were essentially similar to what we saw as the team around the child within the communities. But I think there are ideas you could pick and replicate in different contexts.
Okay. Do we have more questions?
I just have actually a quick note from our online audience.
Yes, please.
They just want to say that we are all watching from the NACCW National Leadership in South Africa, and to convey their gratitude to Zenny for representing our country's childcare and youth care sector at such a high-level symposium.
Aww. It's just over here. And could you introduce yourself?
Yes, I'm Carol Cohen from Adelphi University in New York, as well as from the Global Group Work Network of the International Association for Social Work with Groups. So you can imagine what my question is. I love hearing about the case conferencing program, and truly with the entire program that you've developed, it seems that team approaches, as well as in Uganda, really flow all the way through that. But we know that having a successful team is not just bringing people into the same room and having a chart of guidelines on the wall. So I'm very interested in both the challenges you've encountered as well as the methods of bridging these distances between people and the teams, particularly with the children and families, so they can truly be participants in that work. Thanks so much.
Questions over here and then over there. Go ahead.
Oh, I'm sorry. My name is Janelle Lau, and I work with International Justice Mission. We're an international NGO that has offices in a number of developing countries where we have direct services for children and families who have experienced different forms of violence. And my question was, in both of these models, I was wondering what it would look like in a very low resource area, an area where there might be a lot of challenges accessing healthcare, or there might not be a lot of other INGOs or well-resourced CBOs. So what might this model look like in those contexts?
Okay, thanks. And I know we have more questions, so I apologize for not getting to all of them. But to stay on time, we're gonna stop at those two.
All right. I think it is true that there are many challenges. Getting different social service workers to work together to understand each other's role and to understand the common framework from which one functions, because I think with case management there has to be case assessment and there has to be various opinions that come together, and people need to understand these issues with the same value base. So it's not necessarily easy. Some of the solutions, for example, we started is in developing this case management model, is training social workers and childcare workers together. We've already had an experience in one of our rural provinces in Limpopo, where we actually sat together and talked about how could we work together, created scenarios, and taught people how to sit together and work. With the child and family participating, it's a little bit easier, because I think a participatory approach is very entrenched in South Africa, and particularly in the child and youth care field. But I think the point about preparing children to have their voice in a rather threatening case conference is something that a lot of work has to be done, and to ensure that they are protected in that environment. And as you would know, being selective about which issues allow for that. Yeah, I think that when you talked about the low resource community, if I can say that Izibindi is in the most deprived communities in South Africa. We are in the poverty pockets, we are in the historically disadvantaged communities, we are in communities where there is no running water, where children are struggling in schools, where high schools might not be in place. And we are actually, I think I could use the word animating communities, getting communities active, understanding what kinds of resources they should require for children, building safe parks as an example of services, bringing in services for children with disability. So we're accessing resource, and the word access is an important one when you're working in deprived communities, because South Africa does have resources that need to be brought into the right places. And I think the role of the multidisciplinary team and the childcare worker is critical in doing just that, ensuring access to children's rights.
And just to add on the resource-constrained communities, the Uganda model is also, within very poor, remote communities, and in some of them you find they are very far away from the nearest social worker. So you'd have to, sponsor a social worker to move from miles away to come and do support supervision. But I think it helps a lot to have NGOs who are operating within the area. The primary point of entry is within existing community support structures.
Excellent point. And I think what I think is very interesting that we see in low resource settings is you're not so dependent on this sort of formal sector approach. The best practices in the United States and in other Western countries right now are community-based approaches that really come from the ground up. And not to say that you don't need a formal sector, but you need those two to meet. And I think that these models are showing how that can be done, that there is both the community side and then the more formal structured side, or they're both structured. But I think that's a nice example of that. So unfortunately, we are going to have to close, but Jim is going to help us do that. So if he could come up.
That's me. Yes, I'm the chair of the steering committee for the Alliance, and I have a few closing comments for you and for Zenny's office, who are all listening. I want to tell you, those of you who are in Zenny's office, she is a terrific advocate for the work you're doing and for its implications for other places, and that's why she is such a terrific steering committee member. All I can say is, wow, what great presentations. I mean, great presentations to start with, and all the panelists. Let's give them all a hand. I mean, they were just great. I mean, for me, there were some key messages about the critical role that the social service workforce plays in serving vulnerable children and families, and starting with Gary's, both his imagined remarks, but also the description of the kind of dire circumstances in which a lot of people live, not just emergency circumstances, but everyday dire circumstances. And that's something for us to keep in mind as we think about workforce strengthening, because that's the place where the workforce works and more is needed for that. It's a complex environment. It's driven locally. I think just from the last comments around the ground up. We had a long discussion in our steering committee meeting about the difference between evidence-informed practice and practice-based evidence. And we think we need more practice-based evidence, what's going on out there that works and what can we learn from that at a local level, and then how might that be communicated for people's consideration around adaptation. Lots of interesting kind of discussion around gaps and potential solutions. Including or what I would call solution movements, the global partnership. I mean, getting a look at that and what and the potential of that. The growing evidence base. I mean, the evidence meeting tomorrow, but also just some of the presentations up here around the evidence, and hopefully the Alliance as a kind of a continuing working towards solutions. In terms of the evidence, just a second point, it is growing and it's great, and it can our work tomorrow is going to contribute to that, and yet there is a challenge, and the challenge is to say, how do we grow the evidence base while at the same time realizing that life goes on, that policies are out there to be made, to be influenced, to be advocated for, practices are happening. So how do we determine when we have enough evidence, or at least sufficient evidence, recognizing it's never going to be perfect, to support what's happening at a kind of a local level? And that's a challenge, because mostly the tendency is for people to say what we really need is more research on this, and we probably do. But what do we say is, in the interim, here's something we can recommend? And I think there's a lot of that, and I think we need to look at that both tomorrow and beyond. It's a little bit, I think, from Sarah's comment, one of the quotes in that, and I'm probably going to misquote it, but it's to act urgently and innovatively while at the same time working towards longer solutions. But I think that's the challenge, and evidence fits into that. Lastly, just a kind of thank you to the people behind the scenes who worked on this, and that was Denise and Alex and Jennifer and Maeve. Are they here? Yes, they're here. They may still be behind the scenes, but thank you very much for making this happen. It's obviously complicated to put together something that has lots of different moving parts, including people online, and appreciated that, and appreciated you stepping in and saying we have a comment or a question from people largely in Zenny's office, but I'm sure there are others out there. And a thank you to the IntraHealth, who acts as a host for the Alliance, and a pitch also. And Karen, I think Karen Blythe is here from IntraHealth. She's here right here. So we appreciate the work that you've helped us with over the last 3.5 years. And then just again, a pitch to take a look at this. but also, I mean, we're trying to create a sense of participation and involvement and contribution. So if you see things in here that you have comments on or that you want to add to, there are places on the website to do that, and we encourage you to do it. If there are, for those of you that haven't joined yet, there are applications. There's a form that you can fill out there on the table. And for those online, should there be anybody online that hasn't joined yet, we encourage you to do so. And that's it. I really appreciate everything. Thank you very much. Oh, I forgot. For more information, there's the website.